Hello. Thanks for joining us for the latest in our continuing education series webinars. This particular one is ventricular assist devices for the telecommunicator. My name is Lee Santel. I'm with the Rockland County Sheriff's Office in downstate New York, like in the bottom part of the Hudson Valley, just above New York City. Rockland County is the smallest county in New York State outside of the 5 boroughs of New York City, but we're pretty well populated. We have a population of about 325,000. And our semi-consolidated county PSAP is answering about 225,000 calls per year, about 100,000 of which are 911. The remainder are 7-digit. So there's my contact information up there on the screen. Of course, as I always say on these webinars, I love to hear from folks out there. Please feel free to reach out by email, by phone, smoke signal, whatever. Please feel free to reach out if you have some comments, if you have some feedback, some questions, anything else like that. I do enjoy hearing from the folks out there. We also have the link for our Facebook page there, facebook.com/44control. We're not doing any live training right now due to coronavirus, but we're hoping to start that up in a few weeks. So when we have in-person trainings, we always post them to Facebook first. So if you're not following us on Facebook, maybe check that out. Quick disclaimer, because the lawyers make me do it, this webinar is for informational purposes only. I am a member of APCO and the Atlantic chapter, and I'm on the training committee, and this presentation is being given in conjunction with the Atlantic chapter training committee, but I don't directly represent APCO International, the Atlantic chapter, or their programs, so make sure you're always following, your local procedures, policies, laws, and directives, and your agency's local, where we're talking about a medical thing here, so make sure you're following your agency's medical director in all things, because every agency is going to go a little bit differently on that. Quick commercial before we get started. If you've seen my webinars before, I always throw this in there. You probably found out about this webinar through some sort of channel for APCO or the Atlantic chapter, through PS Connect or one of the other options. But just in case you're not, so you're probably an APCO member already if you're watching this, but if you're not an APCO member already, I hope you'll consider after the webinar is over, going to the APCO website and joining up. Remember, when you join APCO International, you automatically become a member of the local chapter where you live or work, depending on what you put down when you applied. And if where you live or work is one of the states in the Atlantic chapter, then that would be us. Whether you join Atlantic chapter or another chapter, being a member of APCO comes with a lot of benefits: training, advocacy, networking, conferences, volunteer opportunities, elected positions, social opportunities. So it's a great thing to join. It doesn't cost a whole lot of money. It's only a few dollars a month. It's super easy to join up. If you're not a member already, after the webinar is over, I hope you'll consider going over to the website at www.apcointl.org/join. Just put in your credit card information, and it's a 5-minute sign up. You can join up right then and there. I hope you'll consider doing that if you're not a member already, and they'll send us a commercial. So let's get into it. What are we going to talk about? We're going to talk about what a ventricular assist device, or VAD, is. And some of the people watching this webinar might either not be familiar with a VAD at all, or they might have heard the term but not really know what it is and why you would have a VAD, why a patient would have a VAD. So if that's the case, we're here to sort of clear that up for you. They're becoming more common. I don't think they're super common, but we're definitely seeing more of them than we used to. The technology has gotten better over the past, 10, 15 years. So they're definitely becoming more common, and it's something, additionally, even if you know what VADs are, you may not be realizing why it's important for the telecommunicator to know what a VAD is and what a VAD does. And also because although VADs are really great, incredible devices, there are potential problems that can occur with VADs. They are not foolproof, and people may be dialing 911 to report either it's a VAD patient having another emergency, or they're actually reporting a problem with the VAD, which can be fatal. So for that reason, telecommunicators and also really responders, police, fire, EMS, anybody who might be having contact with one of these patients should know what a VAD is and a little bit about how it works and what to do if things might happen. And at the end of this webinar, I will talk about what our agency is doing in terms of emergency medical dispatch for VAD emergencies. Obviously, EMD programs vary depending on your agency and from place to place, so I can't give you concrete information as to how to handle these calls, but we can talk about what we're doing to handle these calls when, should they come in or whatever. All right, so to talk about what a VAD is and how it works, we do have to cover about 60 seconds worth of cardiology. If you're an EMT or a paramedic, this stuff might be second nature. If you're not an EMT or a paramedic, or maybe if, like me, you slept through the cardiology class when you were in the academy, then you probably should listen up. We're not going to go super far into it. We don't need to worry about all the different biological functions of the heart, but we do need to talk a little bit about the chambers of the heart and what they do. So when we talk about the heart, we see that the heart is divided up into 4 chambers. We have the right atrium here, we have the left atrium here, we have the right ventricle here, and we have the left ventricle here. Okay, so those 4 chambers of the heart, we don't need to get super far into what they do, except for this one right here. This one, the left ventricle. Remember, when we say left and right, we're talking about medical stuff. We're always talking about the patient's left and right, not our left and right. So we have the left ventricle over here. The left ventricle, unlike the other chambers of the heart, which push blood around, the left ventricle has to push blood in a very specific way. The left ventricle pushes blood out of the ventricle and up through this valve into the aorta, which on this drawing is this red tube right here, this red pipe. It pushes blood out through the aorta, and the aorta sort of branches off and distributes that blood all throughout the body, and I mean the entire body. The entire body relies on blood flow from the aorta and, by extension, from the left ventricle. We're talking about blood for the whole body. We're talking about blood for the brain. We're talking about blood for the heart itself. We're talking about blood for the other vital organs, blood and oxygen supply. We're talking about blood and oxygen supply for the whole body, to the fingers, to the toes, everywhere. And that means that the left ventricle has a super heavy lift. Left ventricle's got a real heavy burden. It's got a lot of work to do. It's got to push. Remember, the entire heart is only about the size of a clenched fist, roughly speaking. So you're talking about a small part of the heart, a small part of the musculature of the heart that's really got to do a real heavy push. It's got to push blood out with enough force, and reliably so, with enough oomph, with enough pressure and volume. It's got to push out enough of a quantity of blood with sufficient pressure to supply the entire body, from the brain to the organs, to the fingers, the toes, everything. And that means that the left ventricle really has a really heavy workload. You can see in this cross-section image that we have here, it's not exactly anatomically accurate, but it's close. You can see in this cross-section here that the walls of the left ventricle tend to be very much thicker and burlier than the other sections of the heart. It's a very thick and muscular walls of the left ventricle. And that's because it's got a lot of work to do. It really has to push out with a lot of force in order to get that blood out to the body reliably, keep the brain going, keep the vital organs going, keep the body going. So sometimes patients will run into trouble. And the trouble, there can be a lot of problems with the heart, but specifically we're going to talk about when the patient has a problem with the left ventricle. The left ventricle can run into trouble. It could be that the patient has a heart attack and the area of the heart that's damaged is the left ventricle. It could be the patient has a drug overdose and that affects, the heart's function. It could be that the patient has an infection. That's not necessarily uncommon, where the patient has an infection that affects the heart and the left ventricle is damaged. Remember, the musculature, the tissue of the heart is a very special kind of muscle tissue in the body. Once you lose it forever. Heart tissue doesn't grow back. So if you have a heart attack or infection or something like that, and part of your heart muscle gets damaged, that part of the heart muscle is dead and damaged forever. And it's never going to come back no matter what you do. So, obviously in any part of the heart, if there's damage like that to any part of the heart, it is obviously a serious problem that requires medical care, and sometimes patients don't survive. But in this case, we're going to discuss, that situation where the left ventricle is the part of the heart that's affected. When the left ventricle is the part of the heart that's affected, it can have a really profound impact on the patient's health and long-term survival. Because, as I said, the entire body, including the brain, really relies on the left ventricle to get that blood out the door, to get it through the pipe, the aorta and to get it to where it needs to go. And if the left ventricle is not operating at peak, optimal work, if it's not able to put out the necessary amount of oomph with every pump and get that blood where it needs to go, the patient can be seriously affected or die. And when the ventricle is not putting out enough blood with every pump, it's not beating adequately enough, we call that condition heart failure. And I'm generalizing a little bit for my EMS peeps in the audience who are listening, but heart failure, in a word, heart failure, to summarize, heart failure means that the heart is not pumping blood adequately enough to sustain life, or at least not in a healthy fashion. This can actually be different parts of the heart, the atria and the right ventricle and so forth, but the most common one, the one that we kind of think of as sort of a textbook case of heart failure, is when the left ventricle is not able to maintain the blood pressure. It's not able to put out enough blood to make everything work properly. We call that heart failure. The amount of blood that the heart is able to put out with each pump into the aorta, the amount of blood that empties out of the heart, is called the ejection fraction. That's the volume of blood that exits the heart in every wave, so to speak, in every pump. And if the ejection fraction isn't high enough, then the patient could have severe problems or even die. So that we call that heart failure. Now, again, heart failure can be caused by anything that affects the ability of the heart to pump. In this case, we're talking about a situation where the left ventricle is damaged in some way and it's not able to pump out. And yeah, as we said, there are many things: drug overdose, a traumatic injury like a car accident or a bad fall or something that damages the heart somehow is a possibility. Infection, drug overdose, a heart attack. And also even old age. I mean, when people get older, naturally speaking, most people, as they become much older and they get into their, 70s, 80s, 90s, their muscle function just doesn't work as well as it used to. And that goes for their whole body, right? They have less muscle function than they used to, and that includes the heart. The heart, including the left ventricle, can have a lesser muscular function. Their muscle function could be impaired. And that includes the left ventricle, and they may have heart failure, which can onset in old age. But it's not just old people, even young people. It's not uncommon. I'm not saying it happens all the time, of course, but it does happen where, for example, you have, and we'll see a video a little later on of kind of like a classic case. A mother, a young woman, she's like in her 20s or 30s. I mean, she's a young, healthy woman, and she goes to the hospital to have a baby, and she gets an infection while she's in the hospital, and the infection affects her heart, and as a result, she has heart damage in the left ventricle, and now she has heart failure. So, I mean, it really depends on how bad it is and how long it lasts. But if it's bad enough and it can't be fixed or whatever, then if it's really severe enough, the patient can die sometimes sooner, sometimes later. But overall, a decreased blood flow to the brain and the other vital organs of the body is really not compatible with extended life. Death will eventually occur, and that's a bad thing. So if you have a patient who has heart failure, what do you do? Well, prior to like the late 80s, they had a few options, and none of them were great. And they still have these options today, but they're not great options. There are some medications that help the heart put out more blood with every pump. They aren't able to make really fix the problem for some patients adequately. They can help. They can take the burden off the heart a little bit. But in many patients, they don't work that well, and they don't get out enough blood like they're supposed to. There are also mechanical pump replacements where they would hook the patient up to large machines that would help their heart, get out more blood with every pump. But we'll talk about those in a minute. But they're not great. They're not great options. Of course, the definitive care for somebody who has a damaged left ventricle or a damaged part of their heart in general, it's not going to get better. It's not going to grow back because heart tissue doesn't work that way. So what do? The real definitive resolution to this is to give the patient a heart transplant, to give them a new healthy heart. But that's really much easier said than done. First of all, heart transplant surgery is a very burdensome surgery that's very dangerous. Many patients don't survive heart transplant surgery due to infection, due to rejection, things like that. I mean, but putting all that aside, finding healthy donor hearts is really hard. There's a huge donor list, a huge list of people waiting to get donor organs, including hearts. And, for many of these patients, they die before a donor heart becomes available, especially if they're already in bad shape and they don't have that much longer that they can wait. They're waiting for a heart transplant and they never get it and they die because the medications aren't enough or the medications aren't working. So a lot of times they would put these patients on ventricular assist devices, which were these large honking things that would be like in a hospital room. And the patient would sort of, be hooked up to this giant refrigerator-sized machine, and it would help their heart work. But these giant VAD devices that were in the hospitals, although they work, there's a lot of issues associated with them. First of all, they're these giant, huge machines that are like tethered to the bed or whatever, and the patient basically is lying in the bed, and they aren't able to get up and move around. They basically spend their entire day lying in a bed or sitting in a chair, and they're in the hospital 24/7, 365, basically for days, weeks, months, years, whatever on end, until either they pass away or a donor heart might become available, and a lot of times it wouldn't. And by the way, being in a hospital your entire life, especially if you're already a very sick person, not really a safe situation to be in. Hospitals are notorious. People get infections and things, especially if you have one of these devices hooked up to you with all kinds of tubes leading into you and stuff like that. These patients are usually compromised and sick to start with. So the bottom line is these patients typically would have a poor prognosis. They would die before a heart transplant became available. And to be honest, even if they didn't die before a heart transplant became available, it's a really lousy quality of life. These patients are basically lying in a bed like a zombie for the rest of their lives or whatever, and it's really just not a good situation. These ventricular assist devices that they would hook them up to, they're not artificial hearts. Their job is to sort of connect to the ventricle and help the ventricle push out blood where it needs to go. It's sort of like a turbo booster for the left ventricle, or like a pump assist for the left ventricle. It doesn't replace the heart function. The heart still has to beat. The ventricle still has to be beating as part of the heartbeat. But these ventricular assist devices are good. They can take over quite a bit of the function. We see that there are some VAD devices that can take over as much as 90% of the ventricular function and take over 90% of the pumping power. So that is good, but again, before modern times, before let's say the early 90s, they were a stopgap measure at best. The patient would be lying in a hospital bed with all these tubes, and it's very difficult. A lot of tubes going in, big risk of infection. The patient, would be uncomfortable and sort of confined to a bed, not really be able to move around, poor quality of life. Hopefully, even if they didn't, that's assuming they didn't get an infection and die or whatever. It wasn't a great situation. They would attach VAD devices. There actually are VAD devices even today. There are VAD devices that connect to the left ventricle, which is the most common one. There are also ones that can help the right ventricle. Some people do have damage in the right ventricle. And you can have LVADs, as they call, left ventricular assist device, or RVADs, right ventricular assist device. There's actually also the BiVAD, which works for both ventricles. We do it, but the left ventricle is the one that is sort of the textbook case that we think of the most often when we think of a ventricular assist device. So that's what they used to do. What changed with VADs that all of a sudden VADs are like this amazing thing that, really making a big difference for these patients? If they've been using VADs all along in the hospital or whatever, and it's not a good outcome, what's the whole point of this conversation? What changed in, let's say, the early 90s was advances in technology that enabled them to shrink down the size of the VAD considerably. What used to be this giant, refrigerator-sized thing or whatever that the guy was tethered to the hospital bed and he spent the rest of his life that way, they were able to shrink down the VAD so extensively using new technology that the VAD was small enough to implant inside the patient's body, and the patient was no longer tethered to this giant machine. And that had a number of advantages. First of all, obviously, the quality of life. The patient was able to get up and move around because the device was almost entirely self-contained within their body. That's number one, within their chest or abdomen. And number two, the patient only needed to have one wire coming out for power. You didn't need to have, 8 or 10 tubes coming in and out of the patient's abdomen. Much lesser risk of infection, much lesser risk of tearing and bleeding and things like that. Let's take a look at an earlier model of VAD device. This is an older model of VAD device. The reason I say it's an older model is because it has this rotary pump. The impeller inside for the pump is a rotary style. It goes around and around like a fan blade, like a box fan. So you can see over here, this VAD device is implanted directly into the patient's chest in an open heart surgery. And they kind of basically cut like an outlet hole in the bottom of the left ventricle. There's a tube that runs out of the left ventricle. And when the blood enters the ventricle, the blood is routed into the rotary pump where it's pressurized and sped up, and then it's ejected back out directly into the aorta. So that's how these VAD devices work. They would sort of like substitute the major pumping function of the ventricle and sort of turbocharge the blood coming out so that it was ejecting from the heart into the aorta at a proper pressure, at a proper volume. And you can see over here on the right-hand side, you can see what a difference it is for this patient he's now ambulatory. He's able to get up. He's able to walk around. There's no longer, 6 or 8 tubes coming in and out of his body. There's just the one thin tube that includes the electrical wire and sometimes a control wire as well. It's hooked to a small little device for controlling it as needed. And there's a battery pack. The battery is worn either on the belt, or more frequently they wear it like in a holster under their arm, like an underarm gun, pistol holster. Frequently they have 2 batteries. But this is, while it's certainly not perfect, this is a far cry from the previous, version, which is where the patient was lying in a hospital bed with all these tubes coming in and out. And at a high risk of infection and everything else. This is while not perfect, this is far safer and far more effective, and certainly from a quality of life perspective. What a difference for this patient who's now able to get up and walk around. And these VAD devices are extremely effective. The ones that are implanted are extremely effective. I mean, I've encountered some of these VAD patients in the field, and I mean, I see these folks out there. They're running around. They're playing basketball. They're with their kids, their grandkids, whatever it is. They're doing all kinds of things, and they really work well. In this image right here, we see this is a slightly later model, and the reason I say it's a later model is because it uses more of a corkscrew drive. It doesn't use the rotary impeller anymore. They found out those rotary impellers, they can cause blood clots and they break a little more easily. So the later models now use, this is the LVAD device itself right here. The later models use a corkscrew, a screw drive that's inside, and it turns around and around, and it pushes the blood out without the rotary action of the rotary impeller. But basically, otherwise the function is largely the same. We have the sort of like pipe cut into the ventricle. It comes, when the ventricle fills up, the blood filters out. It's drawn into the pump, and the pump pumps it out directly into the aorta, where it goes out to the body at the right pressure and volume. And you can also see here the one wire, the one cord or cable that does have to be, passing through the patient's skin, and that's something that is still a risk, but certainly better than the previous iteration. And it leads to a control pack. The controller is usually, they wear it in a fanny pack, or they wear it on their belt or things like that. And then this particular picture also has the more modern style of battery pack where it's worn under the arms. And typically there's 2 batteries. The device is designed to run on one battery. The second battery is just like a backup. It also lets you switch out the batteries. You have to switch out battery A, so the device uses battery B temporarily while you switch out battery A. But the patient has to be on battery power at all times. To look at the cutaway view here, you can see in this photo, you can see that sort of worm screw drive that turns, and the blood passes through and goes out to the aorta, and that's how it works. So, in essence, the VAD is basically, whether it's an LVAD or an RVAD, really, it doesn't replace heart pump function, but it's sort of like a turbo booster or a turbocharger for the ventricular function, the ventricular pump function. But unlike the previous versions of these devices, which were these big machines with many tubes and things like that, these are small and portable and powerful enough and reliable enough to be implanted in the patient's chest directly. And they don't, they do have to have one small hole in there for the wire for the controller and the battery, but overall it's far superior. And as someone, I don't want to say I've seen zillions of these patients, VADs aren't that super common, but for the ones that I've seen, and I've seen a few, the change is really it's just an amazing, amazing change. These patients, you see them in the cardiac ICU, And, frankly, some of them are barely alive. I mean, they're just, they're at death's door, and then, they can barely move, they can barely get up and breathe, they can barely talk, they can barely get around, and then they put in this VAD device, and I mean, just a stunning change to see these patients getting out and enjoying life and going to work and being with their families and playing sports and all kinds of things. So, while they're not perfect, but they really can make a huge difference. As a matter of fact, in the beginning, when VADs were first becoming a thing, like in the 90s, doctors were implanting them as what they call bridge therapy. In other words, they were giving you the VAD temporarily so that you could stay alive a little longer and more comfortably until they could find you a donor heart. They call that bridge therapy. We're seeing more and more patients who have decided that once they have the VAD and they're comfortable with the VAD is working, they're familiar with it, it's part of their life. We're seeing more and more patients who decide that they don't want the heart transplant for one reason or another. And remember, a heart transplant surgery is very risky. Many, I don't say many, but there are a percentage of patients who get heart transplant and they die as a result of the transplant surgery, rejection or infection, whatever. So for some of these patients, they may decide, what, I've had my open chest surgery, they've put in the VAD, it's working, let's leave it. And we call that destination therapy. These patients are in a position with the VAD where basically it's good enough to stay that way permanently. And that's a real startling departure from the way it was prior to the time the VADs began to shrink down, because forget about destination or bridge therapy, these patients would usually die. And now it's come so far that they're now on destination therapy. What a huge difference. And we expect, as the years go by, that these devices, maybe we'll be able to get to a point in the future where the batteries can be implanted as well or something like that. And who knows? So I'm going to show a real short video from Thoratec, which is a big manufacturer of ventricular assist devices. It's a little bit of a promotional content, but I obviously don't necessarily endorse any of the products, but it gives you an idea of what VAD patients can do and how their life is with the VAD pump.
My heart failure was diagnosed in May of '07, about a week after I had our first baby. I had a girl, and first developed symptoms of pneumonia, and then it led to symptoms of heart failure, and was then diagnosed with postpartum cardiomyopathy. I hadn't really heard of postpartum cardiomyopathy. I hear of, obviously the postpartum depression and that type of thing. It was, a shock. When they first brought up the idea of an LVAD, and that was definitely maybe going to be what was needed, I had heard of it because I am a physical therapist and I do some work in cardiac rehab, and one of my patients had one, and so I definitely had heard of it, but still surprised because I didn't think it would actually be me. I was part of the decision, and my husband, and my family was there, my parents were there. We were educated on the different LVADs that were available, and we had decided on the HeartMate 2, that seemed to be the best choice to go with in my situation. It was just a normal recovery after a heart surgery, doing a little bit more each day, progressing my activity a little bit more each day, and able to get back home and resume my roles as a mother and a wife, and 2 months later went back to work as a cardiac rehab physical therapist. I felt really good, and it's a very appropriate spot for me to be working with other heart patients. Having a few other patients now with the HeartMate 2 is a little bit of a support group. Also with my other patients, even not having an LVAD, but just going through some type of heart surgery, to be able to be empathetic with them and know what they're going through. My life now, 2 years later, most things that I would need to do, I am able to do. So I'm definitely functioning normally, and I feel really good. I have resumed the roles of a mom, I think, pretty much as much as anybody probably does, except for a few of the fun activities. I can't swim with her, but We play baseball, and we go for walks, and we go for bike rides, and we do just our normal daily activities throughout the day without any problems. And I really don't feel limited at all. Maddie knows what it is that I have, and she knows that it's a heart pump, and so she's very good now that she's 2 with helping change my batteries. Okay, put it in. I am still able to participate in quite a few activities in the community. I'm on a bowling league. I was really big into sports before this happened, and so I'm doing what is allowed with the heart pump. Oh, good job! My husband has dealt with the LVAD really well. At times we joke about it. He considers it part of the family. Me and him and our daughter and the pump.
But it is amazing to have the LVAD to have kept her here. The alternative of her not being here versus life with a pump is an easy choice. The things you give up, that doesn't. I mean, it's definitely worth it.
There's definitely a wonderful life on the other side of the pump, and of course, being there for Maddie is probably the best, and that's what their life is about.
Is that where you're going, Maddie?
So that's good.
One day at a time.
As of now, I feel really good with the HeartMate 2, and I have postponed any ideas with being on the transplant list.
Mom, you do first.
I have a lot of confidence in the technology. There are things that I would like to be doing that, I can't be doing having a 2-year-old. I'd like to be going swimming, but obviously you get by without doing those, and you find other things to do. So feeling as good as I do with it, yeah, I would easily be able to live the rest of my life with it.
Yeah, I was experiencing a little audio issues on my end, so I hope if you're watching this, you didn't have the audio lag that I had. But yeah, I mean, it's really a startling change for these patients. They're basically in the hospital or barely getting around. I have a bunch of these videos, which I'm not going to show today, but I mean, really, you see these patients who, I mean, frankly, prior to the development of these VAD devices, I mean, they likely would have died. And to see them up and about, and like you see in the video where she's, chasing after a kid and, going bowling and stuff like that. I mean, that would have been unthinkable. So, all right. So all that being said, we've spoken about what a VAD device is. We've spoken about what VADs do and why they're used. They're not perfect. And, we're short of getting to all the fine print disclaimers from the medical companies or whatever. Let's just talk about some sort of basic things that can go wrong with the VAD. First of all, the device isn't perfect. It might just break. It does happen. Obviously, these are medical devices, but all medical devices can break. Sometimes it can become dislodged or damaged. The wires might get ripped or kinked or pulled out or something like that. The battery might run out. I mean, obviously, they typically are wearing 2 batteries, but it is possible that the battery, might be defective or might get discharged. They weren't able to charge in time. Again, I didn't show the other videos today. I do have another video from Thoratech where it shows inside the patient's home. They have the battery charger at home. Frankly, it looks like like a Motorola bank radio charger. I mean, it's basically just a row of spots to plug in batteries. It looks very familiar if you've seen those kind of things. These patients also, I'm told, when they go to sleep at night, they plug in via power line, or when they're at home and they're not, going out, they may plug directly into the power unit. They sort of become connected to the grid, as it were, and they don't have to worry about the battery. But when they're sleeping, the battery doesn't run out. They plug into the wire, but problems can happen. Things can happen. Of course, site infections. Again, there is that one thinner, there's a thin wire, but it is there passing under the patient's skin, into the body. And of course, that can become infected and cause problems. So there are issues that can happen with the VADs, and some of these incidents might end up as a 911 call that your agency might get. It's not something I think that's going to happen every day. I mean, we don't have zillions of VAD patients in our county, but I think at this point, I would probably say at this point we have less than 100. But we're getting more and more every year. And while it's not a super common thing, I think it's something that these patients might end up calling. And we do have the EMD protocol on that. What's different about these patients in terms of talking to them on the phone during EMD or when you're a police, fire, EMS going out to them? First of all, for a lot of these patients, especially ones with newer worm screw devices, the newer style of pumps, a lot of these patients will not have a palpable pulse. If you put your fingers to their wrist or to their neck, you don't feel a pulse. And if you put a stethoscope to their chest and you try to listen for a pulse, you don't hear a pulse. All you kind of hear is, depending on the patient, but a lot of these patients, all you hear is the sort of buzz. You hear the buzz of the motor as it turns. That motor is basically running all the time. That screwdriver is running all the time. So a lot of these patients have no detectable pulse, and that means that it's difficult or impossible to get a blood pressure on them by a conventional means. So, I know for a lot of us, whether you're talking about in the field for police, fire, EMS, or whether you're talking about the emergency medical dispatcher, the first thing they say is, check to see if the victim has a pulse. These patients could be walking and talking to you and they have no palpable pulse, and it's very odd, but that's normal for them, and that's a big change when it comes to dealing with emergencies regarding these patients. I mean, you can tell right away if you know what to look for. You can tell right away these patients once you've gotten a chance. If you noticed from under their shirt, in the video she wears the battery pack holsters on the outside. I think these days in real life, a lot of people, they wear it under the shirt. They have like the shirt untucked and covering the holsters or the batteries or whatever. But if you've seen these patients and you know what you're looking for, you'll know right away. You can see the batteries and you already sort of have an idea that, that's a VAD patient. So, and one of the big challenges for VAD patients is if they do have a problem with the VAD, or if they have a problem where the VAD is involved, a cardiac problem or something. These patients need special care. It's not like a typical patient, like any other patient that you might encounter on 911 or that EMS might encounter in the field. They really need specialized medical care, and we'll talk about that now. Again, this is for discussion only. Legal disclaimer. You need to have, if you're going to be doing EMD stuff in your agency, you need to have a physician medical director who's watching and directing you as to what to do. So obviously, we're going to talk about what we do at our agency, but we don't take responsibility for what you're doing at your agency. We're just having a discussion for educational purposes. So what are we doing at our agency in terms of our emergency medical dispatch protocol for these patients? Well, one thing that we do at our agency, or what we don't do, is our medical director has directed that we do not perform external CPR compressions on patients with ventricular assist devices. We just don't. Remember, if the patient is actually in cardiac arrest and they have a VAD, most likely, unless a broken VAD is what's causing the problem, or even if a broken VAD is what's causing the problem, the pump is likely still operating. And that means if you put your ear to the patient's chest or stethoscope, you're likely still going to hear the buzzing of the VAD as it continues to go, assuming the battery is on and everything. But performing external CPR compressions, pumping on the patient's chest if they have a VAD, whether the VAD is the problem or not, pumping on the patient's chest can cause serious problems. It can dislodge the VAD, it can rip the wires, it can break the tube out, it can cause all kinds of issues, cause internal bleeding and even death. So our medical director has ordered that if the patient has a ventricular assist device implanted, external CPR is not something that we typically attempt on emergency medical dispatch calls involving these patients. And that also includes field responders, police, fire, EMS. I can't speak for all of our EMS agencies, but I can speak for the EMS agency that I worked at. We would not perform external compressions on that patient during a cardiac arrest if they have a VAD without specific direction from medical control. Another thing that is going to be a little different when it comes to VAD patients is it's critically important to notify everyone, including EMS, especially EMS, that are going to that call that if you find out on the call that the patient has a VAD device, it's very important to let the responders know, especially EMS, that a VAD is present, and that's going to be as early as possible. We really want to get them to know that early as possible. A lot of times these patients require specialized transport, frequently air transport by medevac. Obviously or maybe specialized ground transport, depending on the situation. Usually those things take a while to sort of spin up. So if we find out that the patient has a VAD, we definitely, for a variety of reasons, we want to let the responders and especially EMS know as soon as possible. As soon as we find out that a VAD's involved, even if they're not on scene yet or they haven't, whatever, we want to let them know as early as possible. Regarding use of an AED or defibrillator, again, that's something that your medical director will decide on. Our medical director has said for our agency that defibrillation with VAD patients is okay. Obviously, if you can see the bulge in the patient's skin, for some patients, they implant the device just under the skin, and you can see the kind of, the bulge in the patient's skin where the device is implanted, similar to a pacemaker. Then obviously we don't want to put the pads directly on the implanted device. But other than that, as far as our medical director is concerned, again, consult your local authority. We are able to use the defibrillator if it's appropriate. And again, remember, if your EMD program or other, call processing protocols include telling the caller to check the patient for a pulse, there's a good chance that they're not going to have any pulse at all, or if they do have one, it's going to be very weak. So keep that in mind when it comes to dealing with these ventricular assist device patients. Most patients who have ventricular assist device have a VAD coordinator, and typically the coordinator has a phone number, an emergency contact number. It's either a sticker on the control box or on the battery, or they have a little card in their wallet that says what to do and who to call in an emergency. In my experience, I guess I can't speak for every VAD patient, but in my experience personally, the VAD coordinator is a physician, not a nurse. I mean, I guess maybe you might get to an answering service who patches you through, but the bottom line is, you're not speaking, in my experience, to some, like call center or secretary or something. They're going to put you in touch with the VAD coordinator directly, who is in my experience, a physician. And in my experience, it's usually the actual physician who implanted the VAD to start with. There aren't that many of them. This is obviously a very specialized type of care. So in my experience, when I've had to deal the few times, it hasn't been many, it's been, not that many, but the few times I've had to deal with a VAD coordinator on the phone, it was, in all cases, it was the actual physician who implanted the device personally in the patient's chest, the patient surgeon, who actually did the work. And, basically the number was their cell phone number, and it goes directly to the doctor. So, I mean, in that case, the VAD coordinator is probably going to be the one because, the VAD coordinator is familiar with the patient and familiar with the device and all the other medical history and things like that. The VAD coordinator is going to be the one who's able to give you, who may be able to give you specific care on, specific directions on what to tell EMS to do or what to tell the caller to do, in advance in the pre-hospital environment. And again, that's something that your medical director will obviously direct you on. Our medical director has said that, yes, if there's a VAD coordinator contact available, we should be following their directions or otherwise relaying it to EMS and letting them know what the VAD coordinator said. Frequently, again, in my experience, the VAD coordinator is going to want the patient to be seen. They're going to want to see the VAD patient. The VAD coordinator or the physician is going to say, it's my patient. He or she is my patient, and I know her case, his or her case best, and I want that patient to see me right now at my hospital. And again, even if you live in a relatively urban area, the patient's hospital might be very far away, or only some hospitals do this kind of special surgery. So, depending on where you are and what the conditions are, it may be ground transport, or it might be air ambulance transport, air medical services. That's not uncommon with VAD patients because of their need for a very specialized facility, and because of the fact that they may be very far from that specialized facility, the VAD coordinator might say, I need to see that patient in my hospital right now in Timbuktu or whatever, far away. So medevac may be indicated or emergency ground transport. Again, it depends on the circumstances. Of course, we're going to want to assist EMS with anything that they need. If they need a specialty ground transport, if they need a cardiac ground unit, if they need air ambulance, if they need any of this stuff, as in most things, we're sort of going to be the liaison or the point of contact for this incident so that we can get EMS and the patient the help that they need. And that's obviously going to vary depending on the situation. Of course, many EMD programs, ours is no exception. The sort of fallback is if they call and we're not sure what to do or they're not sure what to do or whatever, I think it's fair to say in most situations, it's hard to go wrong with telling the caller, just do whatever the VAD doctor said to do. Do whatever your doctor told you to do in this sort of emergency. I'm told there are some VAD devices that have like an emergency manual pump where you can like pump the like if the motor dies or something, you can manually like pump it with like a hand pump or something. I haven't personally seen that in my practice, but I understand from the manufacturers that these devices do exist. So there may be an option for that. That might be something that your emergency medical dispatch protocol might cover. Obviously, like I said, if the VAD coordinator phone number is available, try to make contact. If all else fails, your EMD program may direct you that if there's no other choice and the patient isn't breathing and so forth and so on, your EMD program may direct you to say, you know what, we got no other choice. The patient's basically, going to live or die. So to begin external CPR compressions, that's something that should be covered by your medical director. Obviously there's a lot going on there, and there is a risk of injury and making things worse there. So I'm not going to give you a sort of verdict on that one. That's something that your physician medical director, should be covering for you in terms of your EMD and your EMS response. I'm going to show our actual EMD card that we use at our agency, Daytona Beach. The fine people at APCO want me to remind you that this content is copyrighted by the APCO Institute and is used under license from APCO. It is not something that you should be using in live call processing, and it is not something you should be using for any reason without a physician medical director looking over your shoulder to make sure. So obviously take all that information into account. But that being said, you can see we do have an EMD card protocol that we use for this kind of incident. It's basically, aside from contacting the VAD coordinator, it's some basic steps that we can tell the caller to sort of check to see if there's any obvious or simplistic problems that we can correct with the VAD device that might be causing an issue. So, instruction 1, listen carefully, check the pump equipment for the emergency telephone number, contact the VAD coordinator, check the pump equipment, see if the batteries are hooked up, see if try replacing one of the batteries with a fresh battery. Maybe check to make sure the cable isn't kinked. Maybe the cable got unplugged from the control box, whatever. And then again, in our program, instruction 3 is don't do CPR. Our medical director has instructed that we are not to direct callers to perform external CPR compressions on these patients. Basically, it's just airway control or defibrillator if it becomes available. I know at the bottom of the card it says go to card ABC for CPR, but they start with airway control instructions, and then the card stops them after airway. So I don't want anyone to get confused at looking at this card. But basically, that is our EMD card in a nutshell. And although I can't specifically tell you what to do at your agency, I hope that this information helps you develop maybe a little bit of a thought as to how your agency would handle these kinds of VAD incidents. Because, as I said, while they're not something we encounter every day, of course, they are becoming a little more common in the EMS world. And when things become more common in the EMS world, then the emergency medical dispatcher or the telecommunicator is the one who's going to be getting that call and is going to want to know what to do before EMS is dispatched and before EMS gets there. I hope you found this presentation about the ventricular assist devices helpful and interesting. I want to thank Thoratec Corporation for providing the video content for this presentation. And again, if you have any questions or comments, or if there's some other questions or information that I can provide for you, please don't hesitate to reach out by email or phone number or smoke signals or PS Connect or whatever works, and I'd be glad to speak with you about it. Other than that, I hope you enjoyed, and I hope you stay well during these trying times. Have a great one.